Good morning, everybody. Welcome to this very interactive and very interesting session that Roop and Sudhir have organized for us. So on behalf of the fine group, Dr. Shefali Gulati from Delhi and I would like to welcome all of you to this fascinating talk this morning based on palliative care and child neurology. This is something unusual that we've started doing in India, thanks to, again, the guidance of Roop. Who's really the pioneer of this fascinating field in neuropediatrics and neuro-adult medicine here in India. I'm going to ask Dr. Gulati now to take over and introduce Audrey to all of you.
Yeah. Good morning, everybody. Welcome, Audrey, who is probably one of the few board-certified neuropalliative care pediatric neurologists. And I think it'll be wonderful to hear her talk about the interface between child neurology and palliative care. Over to Audrey.
Thank you very much. I'm really honored to be part of this and so pleased to join everybody virtually. It is evening here in San Francisco, but I'll say good morning to you all. As mentioned, I'm a pediatric neurologist, but also board certified in palliative care. And I came to it really because I felt that my practice was meeting at the interface between child neurology and palliative care. And I'd like to spend some time this evening discussing and illustrating that for you all. So I'm going to talk specifically this evening about the role of child neurologists in the care of children with life-limiting illnesses and severe neurologic impairment. I'm going to discuss the benefits of having a palliative care mindset when you take care of your own patients and or actually consulting the palliative care team at times. And I'm going to illustrate this with 3 specific cases to just show the impact that these 2 fields can have on each other. So, as we all know, our field is an exciting one with so many technological advances in the last decade, from specific treatments to diagnostic testing, whether it be hypothermia for hypoxic injury or addition of intense neuroimaging or genetic testing. But despite this, there are children that we take care of who will have life-limiting illness or will require chronic treatment and have severe neurologic impairment. And I've listed some examples here, but I'm sure you all can think of examples in your own practices too. Children that come to us often early in life with a diagnosis that is going to have its trials and tribulations, and in which we play various roles. So certainly, one of our roles is to make the diagnosis, and then to fairly relay the prognosis. But our roles also expand from that to managing symptoms, advocating and supporting the patient and the family, and also maximizing developmental potential and quality of life for this child. So, as I thought of those goals for myself, I realized that they overlap with the goals of palliative care quite significantly. And I think the entire field of neurology has been realizing this, as you have noted in your own advancements in neuropalliative care in India. Back in 1996, the American Academy of Neurology actually made a statement that formally recognized the need for neurologists to understand and apply principles of palliative care. And those principles are simple. It's really to improve the quality of life and reduce various forms of distress for both patients and their families in the face of serious life-threatening or life-limiting conditions. Our patients are absolutely appropriate for palliative care. They have high symptom burden. They often have limited treatment options, a prolonged disease course, and a variable prognosis that's hard to predict. In a study of 515 pediatric palliative care patients followed in a large institution in the US, 40% of them had some sort of genetic diagnosis and a large percent of those had either neuromuscular disease or some degree of cognitive impairment. So absolutely, these palliative care patients are already our patients. And our patients need palliative care. In 9 separate published studies looking at the end of life for children with severe neurologic impairment, parents had a lot to tell us. First, they reported significant stress, significant isolation, a lot actually at the time of first diagnosis. And then over time, when we think things are quiet, at periods of relative disease stability, in addition to end of life. And they all expressed desire for earlier involvement of palliative care in the care of their child and family. I actually think palliative care needs neurologists as well. In a survey of parents of children who had recently died, all of whom had had good end-of-life palliative care, those with neurologic diagnoses were less satisfied with the quality of care that they received than were those with cancer or cardiac diagnoses. Those families felt that the children had neurologic symptoms that were not relieved. So this actually suggests that the palliative care team needs our neurologic specialty as well. So really the way I like to think about it, and the model for pediatric palliative care, is what we call the concurrent care model or simultaneous care model. And it really is the philosophy of hoping for the best, but preparing for the worst. Dealing with your ongoing treatment for disease-modifying therapy, if it exists, but also providing that palliative support, not just at the end, but long-term in this child's life. There are certainly critical periods where we should think about either putting on our palliative care hat or referring to a palliative care team for discussion. And those include at the time of birth and or the time of diagnosis, maybe the first hospitalization, the need for surgery, certainly when the subspecialists are conflicting, when what the pulmonologist and the neurologist think is right for the patient are at odds. That's when the family needs somebody to help them look at the big picture and understand what decisions to make. When there are distressing or difficult to manage symptoms or recurrent hospitalizations, and then finally psychosocial changes. The death of a parent can really change perspective, for example, for the other family members caring for a child with life-limiting illness. So I'm going to give you today 3 case examples that illustrate some of these principles. One is what we'll call a lethal disease, one is a known degenerative disease, and then one is simply a difficult symptom. So this is case number 1, taken from my clinic here in San Francisco. Baby S comes to the child neurology clinic at 9 months of age. She was born at term and immediately given a diagnosis of trisomy 18. Her parents were informed basically, these children die. They die soon after delivery, just take her home and love her and don't expect any time with her. So that's what they did. They went home. They didn't establish care with a pediatrician or get any well-child visits. And then at about 8 months of age, they realized they needed help and they self-referred to neurology because they feared she was having seizures. So when I met this child, she was the size of a newborn, very tiny, significant failure to thrive, very poor oral feeder with aspiration and significant irritability in addition to frequent seizures. As you all know, just to illustrate with trisomy 18, it's fairly common with multi-organ abnormalities and a very high risk of severe neurologic impairment. And we do often call it lethal or say it's incompatible with life. But what do we mean when we say lethal? Does that mean fetal death or neonatal death that is invariable or that happens most of the time? Or is this just a higher likelihood of death? This kind of communication, as illustrated here, really becomes crucial. And certainly Lethal diagnoses have other significant symptom burdens before the child dies. And those kind of statements really are important to define well if we're talking about interventions or potential complications. So if you look at the literature for trisomy 18 prognosis, the early papers suggested 50% of these kids died within a week of birth, and maybe less than 10% survived more than a year. But later studies, after the advent of things like feeding tubes, showed that maybe 10 to 13% actually had long-term survival well into the teenage years and beyond. And it was pretty unclear what the predictors of that survival were, but it tended to be that the more interventions, the longer this child survived. So is this just a self-fulfilling prophecy? Do the infants that die in the first few weeks die because the decision is that they will die and they aren't fed? It's a really important question to ask ourselves, but it's also an important question to be honest about, because families will go on the internet and they'll find stories of children with trisomy 18 who are 7 and 10 and 20 years old. And we immediately risk that they lose trust in what we have to say and in the care of the medical community. So really, for families to make medical decisions and for us to help them with that, there are 3 important factors. One is diagnostic certainty. The other is prognostic certainty. And the final is prognostic meaning to the patient and family. So this takes a bit of work on our part to understand and be honest about. And we know from a lot of literature that physicians consider the long-term effects of chronic illness, and particularly of intellectual disability, as negative for quality of life to a much greater degree than do parents. So many families have asked after the fact about quality of life, or do they wish that their child wasn't here, in situations where physicians might say that was poor, they feel differently. So we can't be making these decisions for them without understanding their perspective. In several studies of providers communicating to families with trisomy 18, there have been some really good insights. What these families tell us is that some providers counsel absolute. It's just the facts. This percent die. These are all the negative things. And the clinicians that they trust the most seem to care for and value that individual child. They made them, these parents, feel like good parents and minimized guilt over their decisions. They had knowledge about the condition and its variable presentation, and they understood both the benefits and burdens of interventions. And finally, they allowed these families to balance hope and reality. So for case 1 with baby S, the goal of this family was really comfort for this baby. They wanted to treat her seizures. They declined a cardiac repair surgery, but they did end up agreeing to a feeding tube because they felt that when she was hungry, she was fussy. She has continued to live many years now. She's 7 years of age. She lives at home with her parents and her siblings. She has rare hospitalizations for respiratory illnesses and is on medications for seizures. But her family overall feels that she has brought value to them. She enjoys the company of her siblings and is generally happy and comfortable. But I'll say it actually took a long time to build trust with them in the medical community, because they felt they spent the first 8 months of her life alone at home thinking that their doctors were wrong. To move on to case 2, this is another clinic patient, baby J, who was brought in for concerns about developmental delay. So this child, at 6 months of age, had a fairly recognizable syndrome. She was beautifully alert, but clearly very weak and hypotonic, with visible tongue fasciculations. She had a story of progressive weakness over just these first 6 months of life. Genetic testing was sent, and she was confirmed to have a diagnosis of SMA type 1. As you know, this is an autosomal recessive neuromuscular disease that comes from a mutation of the SMN1 gene, or the survival motor neuron gene, and results in progressive loss of anterior horn cells. Within our genes, we have the main expression of the protein from SMN1, and then we have this truncated SMN2 gene on the same chromosome that is a duplicate with 11 nucleotides different, so that this transcription of exon 7 is excluded and just a very unstable truncated protein is made. The severity of disease, whether it presents in infancy or later childhood, seems to depend on the number of copies of this second gene, the SMN2 gene. So this baby clearly was a neonatal or early infancy presentation. We know other children can present later with this progressive motor weakness, bulbar and respiratory weakness, but intact cognition. And we know that until recently, children with the most severe form died early within the first few years of life with respiratory failure. And the less severe forms went on to death in early adulthood. Until recently, this was a very clear-cut discussion that we had with family, preparing to spend, especially for the infantile form, what short period of time they had with their child, but also preparing for this child to live a short life. Things have changed in a complicated way with new treatment that is wonderful, including the Nusinersin or Spinraza, which has been out the longer of the two new treatments. So it basically works to increase the normal protein made by the SMN2 gene copy by infusing an antisense oligonucleotide into the intrathecal space, stabilizing that exon 7, and allowing more of the protein to be made. This has been shown in both animals and now in children to increase the survival of anterior horn cells and to decrease the degenerative process. More recently, as you are aware, we've moved to gene therapy for SMA with Zolgensma, as we're calling it in the US. So this is basically a wild type or normal copy of the SMN gene put into AAV9 viral capsid and then injected into the body, where it incorporates and allows for normal expression of this gene in the muscle cells. This is an incredible story, and it's incredibly exciting, but questions remain. For Nusinersin or Spinraza, we're doing intrathecal injections every 2 months, and certainly not all children are responsive. About 20% have been shown to not respond at all. And it's also unclear how long it will be effective, or whether it merely stabilizes or can allow some degree of typical development. The newer therapy, Zolgensma, is a one-time treatment, but it is incredibly expensive and is being rationed by hospitals and insurance. It's not something that is available to everybody, period. And it's really unclear how much improvement will be attained. In the published studies, children that were up to 24 months after injection had at least not lost head control or not lost other milestones. Some were sitting very briefly, but in no way had typical development. So there's no question these are probably saving the lives of these children, but these children will continue to need chronic care without guarantees of typical development. So as we counsel and understand, we really need perspective on this. For baby Jay, the parents actually lived many hours drive from the medical center. Mother was home alone with the 5 children, and father worked in agriculture. So every day he came to the medical center, it was the day they had no payment and no money. They did start Nusinersin. The team was very excited for them to have this. It was covered by their insurance, but Zolgensma was not covered and not offered. This meant repeated trips to the city with an overnight stay, repeated spinal taps or LPs for the child, and the family was expressing the fact that this was incredibly stressful. They felt the child did not do well with the procedure, and every time they struggled to pay to get there, to figure out who could watch their other children, and every time they lost income. The neurologist was trying to problem solve, looking for financial support for the family, but frustratingly, sometimes we would set everything up and then they just wouldn't show up for the visit. At this point, we actually asked the palliative care team to get involved and meet with this family, to see how they were and where they were in their thinking. And what we realized is that the desire to trial the Nusinersin was the team's desire. It wasn't the family's desire. They really were aware it might not work and it probably wouldn't give them a child with typical development. They felt like it caused too much discomfort for the child. They felt like they were losing time with their other children, losing their livelihood. And in the end, they were able to express their desire was to be home with their whole family and with this child for as long as she had. So at that point, they were supported in their decision to stop therapy. The child actually did very well at home for a year longer and then died comfortably at a local hospital after a short respiratory illness. This family, in communication with the neurology team, felt incredibly grateful to understand her disease, to know what to expect, and be supported to make their own decision without judgment about what they wanted their child's short life to look like. This is, I think, a really good example of what good counseling means. It absolutely requires balanced information. You can't just give the worst possible outcome for trisomy 18. You can't just give the sense that Zolgensma or Nusinersin is going to cure a child with SMA. You need to share the spectrum of outcomes and of what the experience is going to be. You need to be honest about risks and benefits. And then you're still not ready. You absolutely need to know the family's values and the family's perspective to actually counsel what's right for that individual child. This was an interesting experience because I think that our neurology team was getting frustrated and angry with this family, feeling that we were putting so much work and effort into getting her treated and they weren't showing up. And the family was feeling respectful of the neurologist and also like they couldn't actually share how they honestly felt. And it was the palliative care team coming in and representing everybody's perspective to each other, being a sounding board for both sides, allowing the neurologists to feel frustrated, but then respectful of the family decision, allowing the family to openly tell a medical team how they felt. That took us from being this wobbly stool of neurologist and family and made us the stable platform, the sort of added team member that allowed for good communication. Our final case is patient R. He is a teenager with the X-linked cerebral form of adrenoleukodystrophy who is quite late into the disease. He has no vision. He has no purposeful movement and has a spastic quadriplegia, as well as severe dementia and epilepsy. He's had several prolonged seizures related to illness and has required repeated hospital admission. The family feels that he does quite poorly with that travel and with the medical visits, and they'd really like to keep him home until the natural end of his life. But their greatest fear is that he's going to die dramatically and uncomfortably at home with a convulsion that they won't be able to manage. And this is not an unreasonable fear. Certainly, neurologic symptoms at the end of life are quite common, whether a patient has a primary neurologic disease or not. So about 15% of all palliative care patients in the adult setting reported some sort of neurologic symptom. It might be confusion or poor sleep or delirium or functional difficulty, for example, with movement or walking. And about 34% reported those symptoms in the last 2 weeks of life. Seizures in particular are common at the end of life. 10 to 15% of adult patients in palliative care have seizures near the end of life. And that rate is likely higher in children, although not well quantitated. The causes are myriad. Maybe it is their primary CNS disease. For some, it's hypoxia and related CNS injury leading to seizures. For some, it's electrolyte derangement from dehydration or other organ dysfunction, in particular renal and hepatic dysfunction, poor absorption of medications or side effects of medications, some that we give to treat other symptoms at the end of life, as well as perhaps edema or new CNS hemorrhage near the end of life as well. So no matter what, I think we all recall seeing our first seizure in a patient, and we know they're distressing to observe. They manifest with loss of consciousness, choking sounds, color change, uncomfortable looking movements, in particular convulsions, and family members who witness seizures are typically quite frightened. In a survey of parents witnessing their child's first seizure, the majority actually thought their child was choking at first or thought their child was dying. The number of parents just across the board seeing their child's first seizure who attempt some sort of cardiopulmonary resuscitation is actually pretty high. And we've probably all experienced this in the hospital. Even when our patients are on the ward and have a seizure, the excitement amongst the staff and pediatricians running to the room and figuring out how to manage this remains high. These are hard to look at. It would be distressing to think of that as your child's end of life experience or your own end of life experience watching your child. 30 to 60% of parents surveyed who had witnessed their child's seizure later had some kind of post-traumatic stress disorder. And certainly the unpredictable nature of seizures, you never know when they can come, causes a lot of anxiety, as well as I've mentioned, the fear of an untreatable seizure or a terminal seizure event can really cloud the attempt at any quality of lifetime at the end of a child's life. So this is where we can play a role with our palliative care colleagues, really helping them to prepare for seizure in a patient at the end of life or on hospice, by helping to anticipate who's at risk, by helping to prepare the family for the event, having appropriate prevention medications and rescue medications, and then having the right goal. And the goal will essentially be comfort, minimizing visible distressing symptoms and treating specific symptoms like the shaking or gasping at the end of life. So we all teach our parents and families about seizure precautions. These may also apply in hospice if a child remains active, safety against falls, safety in the bath, etc. And I think that seizure first aid in particular helps families have a job, helps them not feel helpless watching something happen, and can certainly improve respiratory symptoms in a patient during a convulsion. So reminding parents about the rescue position, giving them suction equipment if that's appropriate for their care, making sure they don't put anything in the child's mouth. And likewise, if we know a patient has had seizures prior, we would be giving a prevention medicine to start with. The type of medication we pick would be based on the same things that you would think about in your profession, with the main caveats being administration route. If a patient is having trouble swallowing, we might have to think about whether medicine is given by a feeding tube or in other ways, and also drug interactions with the rest of their symptom management medication. I think the hard part for seizures at the end of life is our rescue plan. How do we deal with status epilepticus or a terminal seizure at home? So not in the hospital, managed by parents, not by nurses or physicians, with a rare exception where there are home nursing providers, with typically no intravenous access, no ability to give intravenous medication, no EEG to monitor, no intubating, and typically no plan to do CPR. How do we do this? This is something that is an important part of the hospice world and is not really very well understood. We certainly know how to define status epilepticus. We know even in our healthier children, there's mortality for untreated status, but the actual course, what happens if a child goes into status epilepticus at home and we don't or cannot treat it effectively? What happens? Most of this is actually based on quite old literature or animal models, and a small amount based on more recent hospice experiences. So the physiology of untreated status epilepticus is important. We know that once a seizure starts, clinically, if we cannot stop it, it can wax and wane clinically for hours to days. It will eventually burn out with the clinical movements stopping, but subclinical seizures continuing. But the time course of that is unclear. It could be quite long. What we know is that if we had an EEG on at this point in an untreated status situation, even when the body no longer had clinical movements, distinct, clear seizure could go on for days, evolving into lower amplitudes, more disorganized, and then finally into periodic discharges. And clinically at this point, the patient is very quiet and is presenting in coma. During this time, however, there are other physiologic things that are happening that can cause distressing symptoms. One being fever. So within 60 to 90 minutes of continual convulsion, fever, often quite high, can develop. And acidosis actually develops quite quickly, with many secondary effects, in particular on the cardiac system. We know that we demarginate and have elevated white blood cells in the serum and the CSF within about 10 minutes of a prolonged convulsion, and can develop rhabdomyolysis in as short as 30 minutes, and certainly after, with the subsequent renal failure. Systemic hypertension and a secondary increase in cerebral blood flow are particularly important in the hospice setting. And someone who has, for example, a brain tumor, having cerebral blood flow massively increase 200 to 600% in a short period of time increases the possibility of herniation. So, as mentioned, intracranial pressure goes up. With acidosis, there are cardiac arrhythmias. Neurogenic pulmonary edema can happen quite quickly. In most of the literature, death is generally cardiac and due to just either gradual cardiac dysfunction or a sudden dysrhythmia. And in younger people, the dysrhythmia is more common. Death may be respiratory from aspiration or rather abruptly from herniation and brainstem injury. But this whole process can take hours to days. So when we think about managing this at home, we want to do a couple of things. We want to get the distressing convulsion to stop. We want to cause electroclinical dissociation as quickly as possible. Make that external convulsion stop soon. And then we want to help minimize fever and then give any medications or oxygen for respiratory distress. Morphine in particular at low doses can decrease air hunger and gasping, which can be obviously quite distressing to see. When we're treating status epilepticus at home without the tools that we have in the hospital, we can use our same medications, but we have to get a little bit creative. You're all familiar with rescuing with various benzodiazepines, and we do have good pharmacologic information on how to give oral or buccal or even intranasal and intramuscular benzos. In hospice, we will sometimes also do subcutaneous with a little, what we would call butterfly needle, a subcutaneous infusion, for example, or even rectal administration of a benzodiazepine. Absorption studies are small, but quite supportive of efficacy for all of these various ways to administer benzos. And then just like in the hospital, we can give a loading dose of an antiepileptic. Although we are using atypical methods, most common is rectal. So making sort of a compounded version of a high dose pill that is the equivalent of their 20 milligrams per kilogram load of a medication and giving that rectally where it can be absorbed quite quickly, or again, giving a subcutaneous injection or infusion. And certainly these methods are off-label, but there are small efficacy studies that have been done for hospice purposes, and the dosing appears to be quite similar to what would be given intravenously or enterally. So for this young man, after some time at home that was of good quality, he developed a fever from what was likely an aspiration pneumonia, and he started to have one of his typical convulsions. It was not short, however, and at 5 minutes, when it continued, the parents gave him a benzodiazepine intranasally, midazolam. At 10 minutes, when it continued, they gave him a second dose of the intranasal midazolam and prepared their loading medication, which had been pre-measured and calculated and was ready for them at home. So at the 20-minute mark, still having full body, very distressing convulsion, they gave him this rectal suppository, which was a mixture of phenytoin and glycerin at a loading dose for his weight. Within about 10 minutes, the outward manifestation of the seizure had ceased. They had a fan blowing on him to cool him, and he was quiet and comfortable for the next several hours. Family was able to take turns sitting at his bedside, talking to him, and then he died quickly and quietly about 3 hours later without any external symptoms of distress. These aren't necessarily happy stories for your morning, but I think they are things that you're probably going to experience in practice, and they do show us that palliative care is part of giving good care to our patients, and that neurologists, we're already what I call palliative care ambassadors. We think like palliative care doctors in many ways. Sometimes collaboration with a multidisciplinary palliative care team will allow the best possible care for our patients and their families. And also our engagement with the palliative care specialty will allow them to benefit from our input on specific symptom management. There are definitely symptoms that we are most experienced with managing, whether it be seizure or severe dystonia, that the palliative care world could benefit from. So with that, I will end and thank you all for your attention. I hope this was helpful, and I believe we may have some question and answer period now.
That was a terrific talk, Audrey. Once again, I think you've convinced many of us that palliative care in neurology is really a emerging field that we all have to take a lot more interest in, learn more about, and then of course translate that into our practice. So excellent talk. Thank you so much. I think there was a question about, there was a question for you from Dr. Karishma, who wanted to know what the approximate price of therapy for SMA. But I think, Roop, has that been answered already?
Can I just share because I put them all together. There were some questions that I had, sorry, I mean, to jump in, but I had some questions too. So I'll just share my screen and you'll be able to see that. Just give me a minute. Okay. Yeah. So, okay. So, yes. You got this. Now let's move on to the next. Now I'm being a little shamelessly plugging the upcoming course, but Viraj, you want to take them? Viraj, you and Shefali? I'll just.
Sure. So I think the first question is from Roop, talking about the difference between specialist and generalist palliative care. And I think we can all read the question. Actually, it's on the screen. Can all our participants read the questions as well?
Yeah, I think so.
I can reference them when it.
So I think I don't need to read the questions out for you, Audrey. I think it's on your screen and you can see the question as well. And then.
So I am by training a pediatric neurologist. I completed that training and took a job as a generalist in our medical center because I was the newest physician. I had a long list of patients, many of whom had already been given a diagnosis and needed long-term care. And as I took care of these patients, I realized there were some skills I was missing. I knew that some of these patients might die in their teens or 20s, but they were 6 or 8 months old now, and I just wasn't quite sure, how do I talk about that? How does that inform how I take care of them? When do I talk about that? And I really felt like I needed some help to care for them the best I could as a child neurologist. So I actually went to our palliative care specialists in the hospital and basically asked them to sit with me, to come to my clinics, to teach me the way to think about palliative care and the way to communicate about decision making, that I think is something that anyone in our specialty can do, and what I would call a palliative care mindset. So it's easy to get busy and follow your patient with Duchenne muscular dystrophy every 6 months to a year, and then suddenly get to the age of 15 and realize that you've never had a substantive discussion about this family's goals when it comes to respiratory support. And I think we, as neurologists, could all become what I called palliative care ambassadors by really learning the communication skills and the framework for decision making that we can incorporate into our child neurology practice. I separately ended up getting a board in palliative care. So some of my practice, I am just a primary palliative care doctor. That is not necessary for every child neurologist. But I think that more and more in our field, to do the right thing for our families, having the mindset and having the basic skills of palliative care, and then knowing when to engage the super specialist in palliative care will be important. There are many ways to do this. I think everything that FINE is doing in relation to palliative care education is such a great start. There are more and more people interested in neuropalliative care groups, people who are like-minded and communicate and support each other. At what would have been the Academy of Neurology meeting last month, we were going to have our first special interest group in that. And I do think that will continue. I know that there is other work going on through FINE to just involve more neurologists in neurology level training in palliative care in various ways. And Roop perhaps can talk more about that.
I'll do that at the end.
Okay. And then the next question was, in my own institution, how often is specialist palliative care called in? And have I seen that changing over time? And how do we get them working together? I've absolutely seen involvement of palliative care change over the last few years with the recognition, and I think our families have told us this, that if we wait until the final hospitalization, when the child is dying, to involve the palliative care team, it's too late. The benefits that the child and family can get of balancing curative treatment and symptom management happen over the long run. So more and more we're involving palliative care at the time of diagnosis, or at the first major hospitalization, or when there's a discussion of a child perhaps needing a feeding tube or a tracheostomy. I think the strategies are really having these ambassadors, having those of us that think like palliative care while being neurologists, that bring it up in case discussions with our colleagues, that invite our palliative care physicians to come to our educational sessions and teach our faculty and our trainees. I think hopefully that answered that one. The next very good question is, what about children where we're not able to achieve a formal diagnosis? And this, I think,
now I can't share my screen. I can't change this. So can you just look at the other questions that are coming in?
Roop, do you need me or can I continue?
Yeah, please. Sorry, I'm on the.
Okay, sorry about that. So I think that despite all our technology, we definitely still have children for whom we see severe neurologic impairment, and we can follow their trajectory, but we don't have a formal diagnosis. So we don't actually have a prognosis. And I think those are difficult cases because the three parts of decision making are rather lacking. However, family priority and preference is not. So that's where that third component of decision making, from diagnostic certainty, prognostic certainty, and family values, that the family perspective becomes more important. And I think many of us do understand, even in children where we can't give a formal diagnosis, we do understand when we see a child whose development will be very limited or who is having regression regardless of cause. And I think we can have the same conversations without full certainty.
Audrey, I'm just going to ask you to answer a question from one of our participants, Dr. Agarwal from Chennai. He asks a question: how do you deal with euthanasia-like talk by frustrated family members of palliative care patients? So so I'm just going to add on, could you talk to us a little bit more about, terms like end of life, do not resuscitate decisions or withdrawal of care and all these terms that are commonly used amongst our neurology fraternity. And could you expand a bit more about how to have these conversations and what do they actually imply for our patients?
Mm-hmm. Sure. So I think that when I'm teaching my residents, I think one term that we never ever use is withdrawal care, because no matter what we're doing, we may be withdrawing technology, but often at that point, we are applying even more care. We're working harder to manage symptoms. So I've tried to remove that phrase completely from our vocabulary and maybe say something like withdraw life-sustaining equipment or support. When we talk about specific goals and decisions at the end of life, we have a very specific conversation to make it clear that we'd like to have these discussions early. We'd like to have these discussions when we are not in the place of making decisions, because this allows us to discuss it with less overlying emotion, to not feel rushed, and we can make decisions. For example, specific decisions. I would agree with intubation, but not chest compression or shocking, or I would do treatment for any infection, but not CPR, and have those decisions made in advance, with the reality being that you can change your mind at any moment, and parents have their right to change their mind. But in the emergency situation, when a child is suffering symptoms near the end of life, it's very helpful to have had those discussions. And that is really part of what I felt in my early practice was lacking. I was taking care of patients for a long time, but then the inevitable, which I knew was going to happen, was suddenly happening, and I hadn't had that discussion. So specifically in the US, within a hospital, a physician would have to write the orders to not resuscitate. It would be automatic that any child would be fully resuscitated without a physician order in place. But the physician order needs to document a discussion with the family. It can be done unilaterally, although extremely rarely, and typically it's done in agreement with the family or with strong recommendation of the physician and family acquiescence. Outside of the hospital, we actually have a form that families have, which documents these prior discussions, and that they can provide if they call emergency services. So if their child is suddenly having respiratory distress, they can call, have the emergency technicians come in, show them this form, and the technicians will know to do everything they can for comfort, suction, oxygen, opiates, but not intubation, because that's been previously discussed. I don't know if there's similar types of documentations or discussion outside of the hospital in India, but I'd be curious. I'm leaving one thing unanswered, and unless you want me to pause, I'll continue with the question of these sort of frustrated euthanasia, help us, end this for our child discussion. We definitely hear that. I think first and foremost, most of us realize, especially if we've worked with a family for a long time, that it's just coming from a place of suffering. The family's suffering, the child is suffering. And I generally will calmly let families know that I understand why they're saying that. To me, that's a sign that the child's symptoms aren't well managed, but that medical, legally, ethically, we do not perform euthanasia, but we will double, triple our efforts for comfort, and be very specific about how we will do that. Get quite aggressive with morphine at home, for example, for pain or respiratory illness. And as you may all be familiar, there is the concept of double effect, in which if I have a child in respiratory distress and I'm dosing morphine solely for the purpose of relieving their respiratory distress and not with the intent of having them die, that is medically and ethically valid. Versus if I'm dosing potassium with the sole intent of having them die quickly, that is not.
Viraj?
Yeah.
Audrey, Dr. Muralidharan has asked 2 questions. One is how to break the bad news. And secondly, he was suggesting that whenever we are taking rounds, we should discuss about the case and then prognosticate and have a whole plan and inform the parent. What are your views on that?
So the first one was about breaking the bad news, and the second one was sort of making ourselves talk about the prognosis and the plan, correct?
Yeah, prognosis and the plan, and share with the family whenever we are rounding. So when we are bedside, we discuss everything because everything is fresh, and then we make a plan, and then we inform the parents, the family.
So I think the breaking bad news part is really important. The first and foremost thing to think about is the context, making sure you have time, making sure that you can sit and spend time with the family, that the family members who need to be there are there, that if another support person, whether that's a spiritual support person or a social worker or someone else, is there for the support of the family as well. And I think that those things, and know that it's one more thing on our list. We better give the diagnosis, we better give the prognosis, but we have another patient in 5 minutes. And I think in a setting like that, I would probably say that I needed to set up another visit and very specifically set aside a longer period of time to do it. We could spend a lot of time talking about breaking bad news, but I think the context, how you set it up, is incredibly important. There are many other aspects to how you say it that probably deserve additional time.
Can I come in on that? One of the things that is part of the course is a whole module.
Right.
Breaking bad.
Yeah, we have a long session on this, but I think important parts are to both be thinking hard about what you're saying, but also be what I call reading the room. If the parents have completely shut down and can't hear you, then we need to, pause and back up and start over. I think the concept of having a discussion about diagnosis and prognosis on our to-do list is really important. And I mentioned the example of following a child in muscular dystrophy clinic and going years and years dealing with the everyday details and forgetting to have that conversation. But I also expect that if we have it every time we meet with the family, they may not want to come see us. So I think there are milestone times when those conversations happen, and certainly at the time of diagnosis, perhaps then at the time of the first major medical complication. Often for children who are cognitively intact, sometime in the age 13 to 15, when they develop their own understanding of their disease, is another important time to have that conversation as well. I wanted to just answer quickly the questions about SMA. I apologize for using an acronym LP. What I meant was a spinal tap with intrathecal injection of the Spinraza.
I think, Viraj, is that what he meant?
Yeah, I think we've answered it. He wanted to know what the short form for LPs were. So we've answered him. We've sent him a message saying that it's summer punctures for intrathecal Spinraza. A quick question from my side, Audrey. What happens when parents don't agree on a long-term plan for their child? I'm sure you face many situations where one parent wants one thing and the other parent wants the other. What would be the way forward in a situation like that?
This is where I think that I happily realized to myself that while I may be a palliative care ambassador, I'm not a social worker or a psychologist or a marriage therapist. And this is where I really involve the palliative care team. We need a chance to communicate with each parent separately. We need to understand perhaps the religious or societal hierarchy that they have, and how to either help bring them together or support what is appropriate for their family. And that feels like a lot to do, also being the neurologist. So that's where, even as a boarded palliative care physician, if I'm in that situation with a family I'm taking care of as a neurologist, I will bring in a palliative care consultation to be able to have that discussion. I would say there's no simple answer. There's no one parent trumps another, one approach, wins over another. I think it becomes a discussion. And in many of the settings where these discussions have happened, we've eventually reached a conclusion, or the child has sort of made the decision for us with a sudden decline. Some of those cases, even if we didn't want to put this child through CPR, we realized it was what the family needed to do to feel like they'd done everything, even in a degenerative case. So sometimes what we do is what's right for the family.
That's great. Thanks, Audrey. Thank you. Shefali, would you like to talk about your questions?
Yeah, I had plenty of them, but the important one thing I felt, Audrey, whenever you have somebody having an acquired neurological insult in a prematurely normal child, it becomes a difficult situation. It's slightly different. What about this in your experience? And we keep talking about parental support and caregiver support. I think we also need to specifically address the sibling support in pediatric situations.
Absolutely. And I think that's one of the things that palliative care providers and hospice does so very well, is specific sibling support. When I first get to know a family, in particular, someone with severe neurologic issues, I make a point of understanding the family context and the siblings so that I can reach out to the hospice or palliative care team for support. I also absolutely agree with you that a child born with dysmorphic features or an abnormal neurologic exam from birth is very different than a child who was typically developing for some period of time before an acquired injury, just in terms of the type of grief that families feel, and also the relative hope that they feel. I think there's more of a conflict balancing hope and reality in those cases, and they certainly can be more difficult for that reason, and require probably a different degree of support for grieving. And again, this is where I would reach out to the social worker or the spiritual provider on the hospice team to help.
Audrey, I know we're running out of time. I'll just ask you brief 10-second thing, which actually already Roop had shown on the slide. One I felt was very important is whether, like we have all this Spinraza and all come up, but we do have many patients on the humanitarian access program. But what about the rest? And there was a patient whose mother with was running around for financial support for 8 days, but by the time it was done through all the channels, the child became non-ambulatory. And what about the other parents? How do we say the treatment is available in the world, but we can't, you know, access through it. I mean, what to do?
Yeah, I think this is such this tragic and ethical challenge for us. And I felt it so much in that particular patient, because the papers about the gene therapy had just come out for that SMA patient, and the whole team was talking about it and relaying it to the family as a cure, and then, oh, you can't have it. And how cruel, how awful. And this is something I think as a group of neurologists, we need to figure out how we work together for, as more and more gene therapy is going to become available, or as more and more expensive therapy is going to become available, we really have to be honest with ourselves that right now it's being offered to a small subset of our patients. And it puts us in a difficult ethical position. I think we can, as a group, lobby pharmaceutical companies and our governments for increasing support of these therapies. I think the long-term benefits and probably the long-term medical costs are lower for many of these if they're offered the therapy. But yeah, it's kind of the heartbreaking reality right now.
One yes or no, Veera, just one second. I just wanted to know whether you in the US have some support for the parents from the job, because they have to take so much of leave. So whether there is some relaxation given so that they are not victimized in their jobs or not. Only yes or no, sorry. And now then Viraj, please.
If someone is a legal citizen and employed in a typical position, yes, there's family leave. But for many of our patients who are migrants or not legal, or work in the fields, there's no protection.
Yeah.
Audrey, I think Roop and I have similar kind of questions for you, so I'm just going to combine them into one last question for you before we end. Could you talk to all of our participants a bit about an advanced care plan and hospice, care, and what that means, and when does one have these conversations and start these conversations and planning with patients and their families?
Sure. I'm going to talk from the perspective of pediatric neurology and not of all of ourselves, although perhaps we all should or could have had similar discussions about our own health. So advanced care planning in the setting of children is a little bit different, because generally decision makers are already obvious. But if there are issues within the family about who the decision maker is, separated parents or conflicts, the earlier those discussions are made, the better. And then the discussions have to start with what are the overall goals for this child. They can be about more than just the end of life. They can be about whether this is a child that we would do an aggressive scoliosis surgery, repair, or other treatments throughout life. Although classically, the discussion is really about at end of life. If a child experienced life-threatening cardiorespiratory or neurologic complication, what decisions would we be making? And you can imagine, for the parents of a new child, a baby being given a new complicated diagnosis, we can't always have that whole conversation the first time we meet them. But we also can't forget about it until they're 15 and in extremis. It really needs to be something that we work on together throughout the time that we care for these children. And I really, for myself, have thought so much about the milestones. Thinking about the first time they're hospitalized, and the next visit, we extend the visit and we have a conversation about what was that like, what did that do for your decision making. There are actual pamphlets and booklets that palliative care teams use to kind of help families think through what are their wishes for the child, what are the child's best experiences, what are the hardest experiences for the child that help them to make some of those decisions. And I think we need to be incorporating it routinely, stepwise in our practice. I think if we had that discussion on day one with, every family, they'd disappear. But as we become a trusted part of their care, we can, and they know we care about their child, and we're trying to give their child the best life, then those discussions can happen more naturally.
That's great. Thank you.
Yeah.
So I guess I get to make my plug.
Yes.
Thanks, Audrey. That was brilliant. I mean, you actually put everything into perspective, and in the questions and answers, I think we've covered a fair amount of ground there too. And I'd like anybody who's listening in and who's interested to keep in touch. We should be able to have a proper course up for you. And yes, Sudhir is even quicker on the draw. So this will probably come through fine. I'm not very sure if it is going to come through fine or we'll be using some other route, because this is basically the Palliative Care Society. So at this moment, early days, but I think in the next 2 or 3 months, we'll have firmer plans. But one target is to get this course going by the beginning of 2021. Thank you. I'm done. Now it's over to Shefali and Viraj.
Well, I think I'm going to say thank you very much to Audrey for an amazing morning here in India. We've really enjoyed everything, and it's been a great interactive session with you. So we're looking forward to many, many more sessions with you over the next few years, we hope. Preferably in person, getting you here once the COVID pandemic ends, run many more courses here with you in India. That'd be fantastic. Audrey?
Thank you all so much for your time too. I really am honored and appreciative. Thank you.
Audrey, you're exceptionally brilliant. Thank you so much. And this is a very much area which is neglected. So it's your help would be required. And this course which Roop is planning would be really good to start. Thank you so much.
Thank you.
Finally to Roop.
Yeah, we can close. Thank you. Bye, everybody.
Bye.
Bye. Bye. Bye. Bye.